Hi, everyone. Thank you so much for joining us for the third Substance Use and Addiction Lunch and Learn webinar. Today, we will be learning about trauma and violence-informed care. This series is hosted by UBC Health and the BC CSU, the BC Center on Substance Use, and was developed with instructors and preceptors in mind as the primary audience. However, we've seen big numbers of students and staff and community members join as well. So welcome to all of you today. My name is Liz Yu, and I'm the Substance Use and Addiction Partnership Manager with UBC Health and the BC CSU. And I'm calling in today from the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. So before we begin, just a few housekeeping notes. This is a Zoom webinar, therefore your participant videos are off and muted. However, you can type in the chat box. Please note that when you do type, there are two options to send to either just the host and panelists or to everyone. So you can toggle between those. And also, if you have any questions throughout the presentation, please use the Q&A function in the webinar, and we'll get to those at the end of the presentation. When you close out of the meeting, you will be redirected to a quick survey link in your web browser. Your feedback's really important to us, and I thank you in advance for completing that and helping us continue to improve this series for you all. So with that, I am pleased to welcome today's presenter, Christina Chant. She is the Director of Education and Clinical Activities at the BC CSU and also an adjunct professor at the School of Nursing, Faculty of Applied Sciences at UBC. Thank you, Christina, for presenting today.
Thank you, Liz. I'm very excited to be here. Since I can't see all of you, I'm going to do my best to be engaging. I first just, we'll go to the next slide. I'll do my land acknowledgement, but it's a little bit too about me. We can talk about the land I'm on today, which I'm very grateful for. So I first just want to acknowledge that I'm a humble guest on the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And I acknowledge the ongoing criminalization, institutionalization, and discrimination against people who use drugs disproportionately harms Indigenous people. And so I think I ask all of you to consider these impacts when we're talking about substance use and addiction in relation to your work and what we can collectively do in working towards justice and equitable care in all the health systems that we work in. Thank you. And to ground our work today, so I've been learning about trauma-informed practice more formally since 2013 as a nurse. My background is working as a nurse for 15 years in primary care, mental health, and substance use. And I also, substance use has really impacted my family. I'm a European settler. My family go back to former Yugoslavia, and both have been in the war and have been impacted by intergenerational trauma. I've lost a parent to overdose and have supported family throughout the healthcare system around mental health and substance use. And so I want to share that just as I have, this work is not just about like the research or the academic side. Many people have shaped my understanding of trauma and violence-informed practice. And yeah, I want to acknowledge the wonderful people I've worked with in the downtown east side, the many early champions of trauma-informed practice and trauma and violence-informed care who have formalized this work and brought it into the health and academic space. And I really want to acknowledge the people who've embodied this work before we had a name for it, because they've been championing that and just in how they show up with each other. And also acknowledge the many who will transform how we think about healing, trauma, and future possibilities of healing and liberation for people who use drugs. So I share that again for us just to, take that pause of like, what does it really mean, not just as a theory, but the practice of trauma and violence-informed care. So this is heavy. We're talking about trauma, and we are living in a pandemic time. And we also have survived 6 years of the toxic drugs supply and toxic drug crisis. So to help with the praxis of this work, I just wanted to start by acknowledging and kind of give us a moment to get back into our bodies. And actually, before I start that, I want to flag too that I will not be asking you to talk about trauma, your own trauma. This is really like an overarching kind of perspective with some pragmatic pieces at the end to take with you as you leave. And so it's really important, one, that you obviously can leave at any time. And if things come up for you, it can be really helpful to do breathing or to get up and move. And so just to bring us in, I would like to kind of walk us through just a little grounding exercise. So if you feel up to it, take a moment in your chair or wherever you're sitting, because I can't see, and close your eyes and just feel your feet into the floor. Feel your buttocks into your chair and the heaviness and the weight and your connection to the ground or to the land. And take a moment to inhale and exhale out your mouth. And inhale through your nose. Exhale through your mouth. Wiggle those toes. Feel them on the floor. And give yourself a moment just to think about something you have gratitude for today. It can be anything. It can be, for the pause that you're taking some time to learn, that you have some delicious food with you, that you're going to go outside for a walk, or even just be grateful for your breath. And just take another inhale through your nose and exhale. Okay, so thank you if you participated, and if you didn't, that is all right. You get to do what you want. So we'll just get into the learning objectives. So my hope today is that you will come away with a bit of understanding of the prevalence of trauma and how trauma manifests in the body, that we'll talk about the connection between trauma and substance use. We'll walk through what trauma and violence-informed practice is, and we'll also talk about how to integrate this knowledge into your practice. And the key kind of thread through all of this, no worries, Liz. The key thread really is, again, that this is not just one thing, right? This is all very interconnected, and we really just want to start, because this is a big topic, with building trauma awareness and then giving you some tangible tools or ways of thinking and bringing it into what you do in your everyday work or even outside of work. Thank you, Liz. Okay, so we have a bit of a poll just to kick us off. So in the comments, if you would like, here's the poll. So can you please select, if you would like to, how familiar you are with trauma and violence-informed practice? And then if you'd like to, in the chat, you can comment what trauma and violence-informed care or trauma-informed practice means to you. It would be great to just see what your familiarity is and how you think about it. Okay, so we have some results here. So it looks like 2%. So one person here could teach it. I would love for you to join me. The bulk of folks are in the category of I'm always learning. So they have some knowledge. And similarly, we have some people here who know some stuff, and 7% who are not familiar with this at all. So I want to say welcome to the people who have not heard of this. It's really exciting that you get to join us on this journey. And for the people who are in mid-range, always learning, hopefully I will bring some new content to your life. And if not, again, I really encourage folks to put comments in the chat, like what your thoughts are. It's always hard with webinars to make them interactive, but we will do our best to kind of hold space in a discussion around both. And just in the chat, hi, Corey. Nice to see you here. So just some thoughts about what it means. So creating a safe space for clients, both emotionally and physically, asking for permission, Absolutely. So we'll talk about this, but concepts of trust, choice, autonomy, safety, cultivating safety are really critical in this discussion. And I'm also seeing, oh, nice to see you, Julie. And thank you, Chloe and Julia, again, of looking at, choice, respect, asking for permission, checking in, reflexivity. And I really appreciate, Julie, the acknowledgement that we don't know what people are coming to us, like what experiences they hold. And I think we can say that for all of us. And when we get into a bit of the data, we'll talk about that a bit more of really how common these adverse experiences are. And I will kind of flip through some language, but they really have shared meaning. So when I talk about trauma and violence-informed care, trauma-informed practice, adverse childhood experiences or toxic stress, they're all kind of coming from a very similar place of looking at what happens in the body with a trauma response. And also in terms of the violence piece, and we'll talk about this more, but is what are these impacts of systems and social structures and how do they impact people on the day-to-day? Hi, Bobby. All right, next slide, please. Okay. So we're going to get into some of the meat and potatoes of this and talk about what trauma is, why it's important, and how it manifests in the body. And this will just give us a bit of a foundation in this discussion. So this is really important to me, and I think also important in the discussion of trauma and violence-informed practice. So when we talk about trauma, we often think about our individual experience or a person's individual experience. And we're not always thinking about what's the big picture here or what is it? So I think just to get into the detail of let's define this topic. Sorry, next slide, Liz. So trauma is both the individual experience. So it can be a response to one single event. And so we can think about that of experiencing a car accident or experiencing some, weather incident that impacted your family or something interpersonal, but it also can be a progression or a series of events. So we've seen that with people having experiences of sexual violence or in experiencing, microaggressions or the continual experience of poverty and the oppression. And that is a continuous experience that people can have that has leads to a physiological response that lives within the body and manifests in the mind. Trauma is very widespread, and we used to think about trauma as, this post-war shock experience, but you'll see even now there are contemporary articles that talk about has the pandemic created trauma or been a traumatic experience for the public? And maybe doesn't fit your diagnosis of PTSD, but people are having the physiological and social and psychological manifestations of trauma that you would typically see. So trauma can really be an individual, group, or one-time experience or series. And the other piece that we don't talk about often with this, because it does manifest differently for individuals, is that people's social station. So when we think about the determinants of health, their access to income, privilege, your social station, your ethnicity, your work, your benefits, where you live, your access to care, all of these factors also are very significant in impacting how someone manifests symptoms of trauma or whether or not they would be diagnosed with PTSD, for example. I also want to emphasize too that in another way that we don't discuss this, but in thinking about global events, so we think about the impact of people bearing witness to the murder of George Floyd and the continuous progression and impact of colonization on Indigenous people and on people of color, that those multiple racial aggressions or hate crimes and progression of those things leave people feeling unsafe every day. So another way of looking at this concept of trauma, again, is thinking about this prolonged toxic stress and what that impact is on a person's body. And how that might be different from, again, the traditional ideas of PTSD and what people might experience when they have that diagnosis. And, that can look like your flashbacks or feeling very unsafe coming out into social spaces. And we'll get into that a bit more, but I really want to emphasize kind of the nuance and also the individual and systems level factors that really influence how a person experiences trauma and also how we conceptualize the topic of trauma. I've talked about this here about how it can be conceptualized and diagnosed in different ways, but I wanted just to lead into our next slide, which is the talking about adverse childhood experiences. So we know that experiences of trauma, particularly in early childhood, can result in poor physical and mental health, and also an increased prevalence of chronic health conditions in adulthood. So also what we see as these manifestations of mental health issues or chronic health conditions or experiences of trauma later on, they can intersect with each other. And like I mentioned, the individual social and environmental conditions also play a role in how that manifests and how the person might mitigate some of those experiences. And so before we get into the specific ACEs study, I just want to share with you too what ACEs are. So adverse childhood events are another way of thinking about trauma. They are stressful and traumatic experiences endured in childhood that are typically associated with, kind of inadequate care and neglect. It can be interpersonal traumatic experiences or social kind of issues as well. The scale in this study was rated out of 10 categories that include childhood abuse, neglect, household dysfunction, emotional, sexual, physical abuse, emotional neglect, physical neglect, household substance use, mental illness, divorce, or having a family member who went to jail. And what these things missed in these particular studies was the larger systems and social conditions that also can play a role in trauma. So I just want to preface that as we walk through this very important study that really has taught us a lot about the global scale of adverse childhood events and also their impact. So the Adverse Childhood Experiences Study is a really critical study that came out in 1998. And I know that is a while back, but it really changed the landscape of how we thought about adverse childhood experiences and the longitudinal impact of health and illness, particularly the concurrent nature of mental health and these chronic health issues. And so the big kind of takeaway from this study was positive and negative experiences of childhood shape our trajectory of health. And you're like, well, yeah, obviously. But this study actually gave us data to show the dose, and that means so like 1 out of 10, like the dose impact really increased the prevalence of the potential of chronic health conditions or mental health or substance use issues. And so why is this study important? So this study asked 26,000 adults coming through Kaiser Permanente, so a US-based insurance company for health, if they would participate in the study and fill out a survey and looked at also their health data, asking them about their experiences of these 10 categories. So that's when I talked about experiences of abuse, neglect, being around a parent who used drugs or went to jail, or kind of those other social indications. And so we'll get into this, you'll get to see the tables, but I wanted to kind of share this with the results, is that the ACEs, so the adverse childhood experiences across this large group of people, were prevalent across a range of populations. So to give you an example, of the 26,000, 52% experienced at least one of the adverse childhood experiences that were surveyed. The most common was people having a parent who used substance use in the household, so it was 25%. 22% of that 26,000 experienced sexual abuse. About 20% had a family member with mental illness in the home. And the most prevalent, and then also high were 26% of that group had experienced physical abuse, 24% domestic violence, and 21% had experienced sexual abuse in the household as well. So this is really significant. And then in another study that was very similar, the Centers for Disease Control in the US looked at a sample of 26,000 adults in 5 states, and the prevalence rates of the adverse childhood events were consistent with the other study. So 60% of those respondents had been exposed to at least one adverse childhood event. And in another study with the Ontario Health Survey, they found 72% of this population sample, so it was of 10,000 people, have reported exposure to at least one. And those ACE categories were a little bit different, but still had a very similar result. And then in a study in the Philippines, of their sample population of a much smaller size, so about 1,000, they found about 73% had experienced at least one of those adverse childhood events. Of those results, men were more likely to report, and sorry, this is of the Ontario Health Study, but men were more likely to report physical abuse and poor parent-child relationship, whereas women were more likely to report childhood sexual abuse and parental marital conflict. I will also note that just acknowledge that these studies did not look into genders outside of men and women. So that is a limitation of these studies. And we'll talk a little bit about that later on. And so just to summarize that, these studies, there were pieces that they didn't look at, like protective factors, the structural and social conditions that would also have an impact, and like stressors that may be outside the household. But that should kind of make you be a bit more like, whoa, if those things weren't included, what would these results be like, right? Because they're still so common. So we'll just go into the table so you can see the distribution of results a bit more here. Okay, so this is the CDC ACEs study and the demographic characteristics. And so you can see the breakdown of these 26,000 people, how many were male or female, the race and ethnicity distribution, as well as some of the further demographics in the slide. I'm just wondering, like with what I've shared so far, maybe you could put in the chat, does anything stand out for you given what we've talked about so far and the table here? So in terms of this pool, there definitely were, yes, primarily white people, and definitely a lack of, I don't think there was significant consideration of sexuality or gender beyond men and women in this kind of study breakdown. But I think given what we know too about social determinants of health, and again, where there's, in terms of health equity and inequities, that we see larger inequities with Indigenous and people of color, again, because of structural discrimination and whatnot, that the results were a bit more, I think, surprising to many, considering that most of these folks here are white and actually more mid to upper range in their economic status, given that they have access to health insurance. So this is just further the prevalence of the ACEs within this same group. So again, you'll see that there was a significant amount of emotional abuse, experience of physical abuse and sexual abuse across these groups. And again, that the exposure to people who use substances was higher. And I think this is a bit surprising, like how high that amount was when you think about like the general population. But I think, again, these are things that we don't often hear people talk about, which ties into shame and stigma around substance use. And this is just in terms of like the overall prevalence. And this is really important when we look again at the likelihood or frequency of further chronic health issues or mental health or substance use issues or suicidality. So what these studies found was that the more adverse childhood experiences that people had, the greater likelihood by a significant amount that they were going to, have a substance use disorder themselves, or were more likely to try to commit suicide, or more likely to experience heart disease or COPD. So this is just important to keep in mind that when you look at like the 4 or more, it's still 15% of women and 9% of men, but less than that, again, like 25%. So it's a quarter of women had one and over a quarter of men had one. And it just, keeps going up. This is quite significant in terms of the results in this one study. The other thing I will note, and we'll talk about this a bit later too, is again that it doesn't factor in what privileges or like the social location of people who participated in the study. And so it's not all lost. If you're like me and you have a few of these, there are a lot of factors that are protective and resilient and that people study down the road. But for this particular study, it focused on these pieces. So this here was a study from the ACEs study looked at specifically injection drug use. And I wanted to use this as an example from the study, just in the context of, again, one of the pieces, I think, of substance use that gets a lot of attention. So what they found was the relationship of injection drug use to adverse childhood experiences is so significant and graded at every step. So you can see that the bottom row, again, looks at the frequency of adverse childhood experiences, and then the top part looking at the likelihood that they have injected drugs. So for people who have 4 or more adverse childhood experiences, it's so more likely that they would end up having injected drugs in their lifetime. And from the study, they found that like a male child with an ACE score of 6 has a 4,600% increase in the likelihood that they later would inject drugs over time and have a substance use disorder compared to a male child with an ACE score of 0. So, it's important again to think about, like, to contextualize this data and think about what is it, like, might this be a response, again, to coping with the significant adverse childhood experiences that they experience as a child? Because if you break down, what does this number 4 mean? Well, it might mean, again, that they had experienced sexual abuse or neglect, or their parents may had a terrible relationship that they were exposed to. Perhaps they lived in poverty. And I don't want to pathologize people. I just want to present that there is this, again, childhood experience picture of a person who grows up into an adult and then carries on their coping, or they're trying to cope with the pain or experiences and suffering of what that might have looked like when they were a child. And I think this is a way, again, of looking at this from a public health perspective of when we think about the, again, prevalence of these adverse childhood experiences and their impact in tying to these results. And I think because we're going to move into like a little bit more about the trauma side of things and the physiological impacts, I just want to highlight too that, like, this is another way of us moving away from looking at necessarily like risk categories of individual behavior, and instead looking at what are these conditions, around this kind of child and family experience that are contributing to the frequency of these adverse childhood events, and what can we do to mitigate those impacts and have build in protective factors. And I think that's why it's, again, important to think about the determinants of health and how they interplay, again, with people's experience as children and exposure to these kind of toxic stress levels or trauma experiences as children. Because, again, the impact of this is these things last a lifetime. So when we think about people having diabetes later in life, or COPD later in life, or substance use later in life, well, some of these experiences are starting very young, and we could potentially intervene much earlier. Next slide, please. So just, again, kind of summarizing here, persons who've experienced 4 or more categories compared to those who experienced none had a 4 to 12-fold increase in health risks for alcoholism, drug abuse, depression, and suicide attempts. So that's super significant in thinking, again, about how we design healthcare systems, how we're intervening early, what programs we're designing early. And these results were concurrent with other physical and mental health conditions. Again, in comparison to the greater number of adverse childhood experiences, and have been replicated over time. Next slide. I wanted to show this slide again to highlight looking at the individual, community, and environmental level when we're talking about adverse childhood experiences, again, to move away from the individual side of things. And part of that is when we are talking about trauma and violence-informed practice, we are acknowledging that there are social and structural conditions that cause violence at the structural level to the individual over time. So an example of that can be housing insecurity, it can be endured poverty, it can be the impact of white supremacy on individuals of color, and the impact of colonization in residential schools over time. So we need to contextualize these results and these responses in this broader context, again, to move away from looking at this individual and what they've done in their life for this result to come about. And I think this picture just, again, like highlights that nicely about the broader impacts and stressors that can contribute to these adverse childhood events or experiences of trauma over time. So for example, again, of just thinking about the built environment, access to nature, access to jobs, access to money, Looking at the impact of intergenerational trauma, and then more broadly, thinking about the social environmental conditions. So what people experience again with enduring impacts of the climate crisis and wildfires, and having access again to support and what that looks like, and feeling that your communities care about you and not enduring social stigma over time as well. So I'm just going to take a pause here because I have talked a lot. And I have a question here, but it is pretty long. So no, that's not a criticism. It's just a small font for me to read. I'm going to come back to this question just because I think it is quite nuanced. But I'm just wondering if there are any kind of comments that you guys or thoughts you have again on taking up this approach from a broader kind of social structural kind of position and the results we've talked about so far. Following this, we will be getting in a little bit more into the physiological impacts of trauma. So we've been talking about these data results, but from the childhood perspective, like what that actually looks like. Okay, well, I'm just going to kind of summarize what we talked about. So in essence, adverse childhood experiences are incredibly common. Of those studies we talked about, nearly 2/3 of those adults had at least one. These adverse childhood experiences contribute to adult onset of chronic disease, such as cancer, heart disease, mental illness, suicidality. And ACEs don't occur alone. If you have one, there's a really high chance that you will have two or more. And the more ACEs that you have, the greater risk for chronic disease, mental illness, development of substance use disorders. Each trauma counts as one. So it's important again to think about that the potential when you have more, you're more likely to have more chronic health issues. And that these ACEs are really responsible for a large chunk of the impact of the cost on the healthcare system and healthcare system resources as well. And we know that these structural conditions create a context environment for people to actually have exposure to more, which is not the fault of that individual. That is, again, our culture, our society, and the context that people live and exist in every day. And I think, again, from that large scale study that I shared, it's particularly, I think, startling or important to consider that most of those participants were white. Most of them were middle and upper class, college educated, had access to jobs, and had access to healthcare. They had access to working or being a part of Kaiser Permanente. So when you think about that, extrapolate it further to other populations who we know experience routine social and health inequities, I think it's jarring to think about what that impact is on those other important communities as well. There have been studies since then that have looked at protective factors and have sought to understand what are the mitigating factors so that people who do experience ACEs are not just dying very early, or how are they getting access to support? What are we looking at? Not these populations, people's experience are not homogenous. So it's important, again, to look at the nuance and look at qualitative data. So we know too that there also is a dose response association between positive childhood experiences. So one of those could be, feeling like you have access to family to support you, or you have access to trusted adults, you feel protected in the home, that those folks in those studies came out still without having a mental health issue in those conditions. They also found that resilience mitigated the impact of these adverse childhood experiences in terms of grade repetition and being engaged in school. Another study found that the number of adverse childhood experiences was associated with social emotional challenges and developmental delay risks. However, they also found that positive parenting practices demonstrated robust protective effects on those children in those studies. And again, for people, so the high counter ACE score, so positive childhood experiences were associated with improved adult health, and again, counteracted those negative ACE experiences in adult health. And again, a gist of it was those positive experiences over time can negate the impact of the early experiences of adverse childhood events. But it's, again, looking at that impact and interrupting that exposure also to toxic stress as a child. So on our next slide, we will have a bit of a video for you, just as a bit of to showcase more about what the physiological effects of toxic stress are on children, and then we'll kind of chat a little bit about that once the video is done. So.
Learning to deal with stress is an important part of healthy development. When experiencing stress, the stress response system is activated. The body and brain go on alert. There's an adrenaline rush, increased heart rate, and an increase in stress hormone levels. When the stress is relieved after a short time, or a young child receives support from caring adults, the stress response winds down and the body quickly returns to normal. In severe situations, such as ongoing abuse and neglect, where there is no caring adult to act as a buffer against the stress response stays activated. Even when there is no apparent physical harm, the extended absence of response from adults can activate the stress response system. Constant activation of the stress response overloads developing systems, with serious, lifelong consequences for the child. This is known as toxic stress. Over time, this results in a stress response system set permanently on high alert. In the areas of the brain dedicated to learning and reasoning, the neural connections that comprise brain architecture are weaker and fewer in number. Science shows that the prolonged activation of stress hormones in early childhood can actually reduce neural connections in these important areas of the brain at just the time when they should be growing new ones. Toxic stress can be avoided if we ensure that the environments in which children grow and develop are nurturing, stable, and engaging.
Given the time that we had, I would suggest there's a lot of data out there around the neurobiology of trauma and the impact and fight or flight response. And we'll talk a little bit about the window of tolerance, but I'm looking at the time and we already are coming up closer to the end. So we wanted to highlight this because this showcases like the impact of long-term stressors and the neurobiological changes that can occur over time. And what this translates into is social and cognitive challenges that can look like difficulty self-regulating emotions, that translate into difficulty creating relationships. It can be challenging. It can for children of looking at their self-concepts around self-worth, self-image. It can make it hard for them to manage and cope with daily stressors. And this often can translate again to children being seen as difficult or challenging when, in fact, they are living in these environments and are experiencing these physical results that they likely cannot interpret depending on their developmental age. And these things will translate into adulthood, right? Like a person's ability to cope with the stress of daily life or deal with difficult emotions, or whether or not they're in a nurturing environment or a safe environment that can help them again grow and take risks and take challenges and engage in life in a fulsome way, right? And that's difficult to do too if your parents come from a similar background where perhaps they did not have those skills and abilities either to nurture them. So when we talked about protective elements of ACEs, I think these are important things to consider, that folks' resilience can be built through, again, not just through their parents, but through their community and having access to trusted adults or people in their life who believe in them, and or if they have access again to different environments where they can experience different things or ways of being that can teach them and teach them how to manage their emotions or develop those skills. So I'm going to, so funny, we're only halfway through my slides. So lots to talk about, but we're going to talk a bit more about how this impacts in adulthood here as well, and how this manifests. So I know we have some answers in this beautiful image, but I'm just wondering if in the chat people want to talk a little bit about what are some things how do you think trauma manifests in these cognitive, behavioral, and physical ways? Is there anything missing or things that you kind of think stand out for you? And after this slide, I'll answer a couple things that have been asked in the chat as well. it's important for people to know when we think about how trauma manifests that this can be really confused with a lot of different health conditions, or it shows up in different ways, right? So we know that in like the psychological way, we think about fight, flight, freeze, and fawn. And what you're seeing in there, again, is say you have an exposure to something that is a traumatic memory, and that it may jack up your nervous system. It tells your brain you're being attacked, but you might not be attacked. And so there's this kind of alignment of experience, but it's actually not aligned, right? So that might show up as, you being really startled in a safe environment and be like, why did that happen? It can show up in sleeplessness. It can show up in insomnia. It can show up in somatic manifestations. So what that means is, again, like having odd physical aches and pains, or, like kind of nervy responses in your hands or in your body. Where it might show up behaviorally is you might avoid activities and not really know why, or the people you're caring for may not know why, but it's just what they do as a protective mechanism. It can show up as hopelessness, social isolation, withdrawal. Cognitively, people may have intrusive thoughts that are reminiscent of those traumas. They might have nightmares, they may feel confused, they might have mood swings. Very common for those to manifest. I'm going to take this time before we jump into the window of tolerance, and I might skip through it actually just because I want to give some pragmatic examples for people to take away with this, even though I also see some rock stars in the chat that I've worked with over time. So nice to see you. So Julia had a really great question here about how do you draw the line around what's trauma and what's not trauma when you think about adverse childhood events? And I think, I've had this question myself, and I think that like it's really up to the individual, when we to self-determine around what they or how they self-identify around their experiences. People can have experiences in life that may be traumatic for someone and aren't for others. And another example is for folks that live in countries, say, where they experience war routinely. They may not find that experience or name it as being a traumatic experience. But for someone coming from a place where war does not occur commonly, a one-time experience of that could be traumatic, right? So it's really only as useful as a tool, I think, for screening to maybe build some self-awareness of being like, oh, that's interesting. But, if you conceptualize yourself as someone who is fine and you don't identify with a lot of these effects, that may also reflect that you have also had a lot of protective things that have happened in your life and privileges that have positioned you differently, or that have given you coping skills that you're okay. And like I said, this isn't an intention to pathologize people or their experiences, but I think is all about building awareness of the commonality of it. And that also, like, one of the key things for anyone is we don't ask people, have you had trauma? What's your trauma? Unless you're a trauma trained therapist. It's more to operate in a way of how we think about, like, contact precautions in healthcare, that like you can assume that many of the people you're working with, and if they do have a substance use disorder, that this is particularly common. And it's not so much about the substance, but why is the person using the substance? What's the pain? What's the suffering? How is this helping you, through that period of your life? And there is a resiliency scale that you can take too. So I really wanted to emphasize that it's not just about being like, oh my God, you had all these bad experiences, it's over for you. But the opposite, actually, of just being like, these are really common and people walk through their lives every day, showing up and being amazing, even though these things have happened. But in the context of substance use, where there's a lot of stigma and shame, it's really important to conceptualize or to understand why and why they might be coping in that way, and what relief that substance might be providing them, that in this society, which has a lot of stressors and doesn't make sense and can feel very isolated and supportive, that may be their best option at that time. Another question we had that was great was about, is there evidence that shows ACEs are associated with social determinants of health? And if so, could there be a cyclical relationship between the determinants of health and ACEs? So there have been some studies that have explored the social determinants of health and ACEs, not from what I've seen, not in a way that shows like this direct relationship. I think it is a hard thing to study when you bring in these kind of social concepts. But given that we have data that looks at the determinants of health and health outcomes and these ACEs studies, that I think that you could make an argument that there definitely is some sort of relationship between these social and structural inequities, and that exposure to neglect. And again, I think about ongoing oppression, racial trauma, experiences of ongoing structural violence and dispossession of land, as well as housing, that all of those factors would absolutely play a role in with a child about their experiences of feeling safe and safety, and how that manifests in the body as toxic stress and kind of comes through in adulthood. So definitely, I won't say that I know all the literature, but I think that, again, that you could make a logical argument for that to be a possibility. The last question here is an interesting question about how does the understanding of ACEs when contextualized help inform a population health approach to substance use versus reinforcing a focus on the individual level of interventions. So I think this is hard. Our society definitely veers to the individual when we think about health promotion interventions, and when we consider also as an individual clinician, when you're working with people, you have this one person in front of you. I think from a population health standpoint, where we need to begin is in doing a better job of collecting the data around who are using substances, collecting data around the prevalence of adverse childhood events in a Canadian context, and also having cross data that looks at ethnicity and social demographics. And again, not for the purpose of pinpointing populations and saying you're more traumatized, but actually to highlight where are we not doing a good job in attending to the needs of those populations. And so in the case, again, where we look at things like housing, income, access to school, built environments, access to parks, we know those are all very critical in cultivating health and resilience in populations, especially for substance use and people who use drugs as well. So I think it's just starting from the collecting data side so we can actually do the research to have the evidence, then to get the resources to do the interventions. And sometimes too, that just means doing the interventions because you know that it may be the right thing to do, right? And I think that's why we have piloted a lot of different things. But yeah, it's a tough one here of looking from the systems level of needing actually the data first, I think, to show the prevalence and why we need to be doing things differently, and to substantiate some of the assumptions that we have that would be beneficial to care for people who use drugs, and do it in a more responsive, compassionate way. So we have 9 minutes left. I'm just thinking here of what might be the best way. Maybe we can move to slide 25, Liz. And then I'm going to pop into some of the pragmatic land pieces, but I'll talk a little bit about the prevalence of substance use and trauma. So, I feel like we've made a little bit of a case here, but just to share some recent studies. So in a recent scoping review, a study found a higher prevalence of ACEs was found in the population, or that there was a positive association between ACEs and the development and severity of substance use disorders in adolescents and adulthoods. In another study, there was a 8% lifetime prevalence of PTSD with a co-occurring 26% lifetime prevalence of a substance use disorder. And they found that individuals with PTSD were 2 to 4 times more likely than individuals without to meet the criteria of a substance use disorder. And in a survey of adolescents receiving treatment for substance use, more than 70% of those patients had a history of trauma exposure in that cohort. And as you can see in this slide, substance use is really common in an international scale, but because of challenges in collecting data and not having common national databases, the statistics really vary. So we don't have the best data available. But we do know, and we commonly know that we've heard this, that stigma and discrimination are huge factors in contributing to overdose death, and also into people not sharing that they have that they're using drugs, or that they might need support around substance use. So, many of these deaths are incredibly preventable, and we need to acknowledge that it is how our systems are designed and how we think about people who use drugs and substances in general that contributes to the continuation of the increase of overdose deaths. Next slide. So again, I'm sorry I'm rushing through this, but just cognizant of time, so in these studies we talked about, they didn't explore a lot about gender beyond men and women. And so I wanted to talk a little bit about how transgender people experience very high rates of gender-based discrimination, harassment, and physical and sexual violence, and trans women in particular at heightened risk. And so again, given the data that we have in these other studies, is that we can make the assumption or infer that, again, that there may be higher rates of adverse childhood experiences for trans people, or how that translates into adulthood and how that impacts, again, whether or not people use drugs. We also know that substance use treatment has largely excluded trans and gender diverse people in care, and that we do have studies that show that they do not feel safe to come into care, and that having access to gender affirming treatment is critical in accessing care and also attending to the high levels of suicidality. So these are all, again, important when we think about people using drugs, again, to contextualize their experience and of why they might be using drugs. But again, not to pathologize their gender for why they may be using drugs. So, important to make that distinction there as well. And then we also just, again, have research that shows that having gender-specific services around substance use, so studies have looked at women and the needs of men, and that there are distinctions, and again, about what feels safe to them in attending to care, particularly given the high prevalence of rates of sexual abuse and sexual assault for women, as well as trans people in accessing care. Okay, so next slide, we're going to quickly go into making it real. So what does trauma-informed practice actually look like in practice? Next slide, please. Okay, so I talked actually more about what trauma and violence informed care is. So I'm going to move to the next slide because I've kind of given an overview about that. But when we're looking at what this looks like in practice, there are 4 key concepts that we're going to get into. And I'm just actually going to move us along to, the 4 principles. So we have building awareness. You're doing it. This is building awareness. This is crucial. This is your foundation. So you need to understand the why. Why is this important? It's really common. It informs a lot of people's experiences. It can change how we think about why people use drugs and what for. And again, to think about it from a broader spectrum of what's going on there, and how we support people. The other piece is about how do we care for people who use drugs in a trauma-informed way. So let's get into our next slide with these lovely pictures. So key to this is offering choice and connection. So when you think about the exclusion of people who use drugs from society and the lack of autonomy and choice that we offer, offering choice and collaboration and connection are critical in cultivating safety. It's important to treat people like adults, to offer care options that are meaningful and realistic and that attend to their daily lives. And by doing this, you're doing one thing that's really important for people who've experienced traumatic events is you're respecting their autonomy when they've had choice taken away from them. You're respecting their humanity when they've experienced a ton of stigma and discrimination in their life. And you may not say, well, not all humans. I've had adverse experiences. Maybe I use drugs sometimes, and that's not a case. But this is more of like a global approach, again, of like, show me that you're excited to see me, of saying, that's so great you came in. I'm so happy to see you. What do you need today? What would it look like to have a good experience in us working together today? And a way of looking at this from an organizational perspective is, again, looking at your policies and programming that you have in play, and also in creating an environment that looks inviting and that is safe. And I wish I could go into this more, but we have 3 minutes left. So I'm going to go to the next slide. Emphasizing safety and trustworthiness. So safety is a really huge concept when we talk about it. And to make it really plain in how you could do that, again, is how you show up as an individual. Start with yourself of, am I self-regulated? Am I showing up flustered? Have I attended to how I'm feeling in this moment? Am I really anxious about this? Because people who've experienced trauma, they can read that. They will read you. And people who have repeatedly experienced exclusion and trauma in healthcare services, even more so, are reading you to see, are you a safe person? And a safe person looks calm, good eye contact, you're engaging, you say their name, you offer them choice and connection, you show them that you really care about their humanity. You're not judging them for using drugs. You're not judging them for their substance use disorder. And if you do feel those feelings, which people do all the time, are you taking time to interrogate how you feel about these things and feel about this person? And what do you need to feel safe in that connection? And how's that working in that moment? And remember too, that boundaries are a really great way to tell someone, how you two can work together. And that doesn't mean that you're going to set them off. And if you do, that's okay. They'll come back and you can correlate and repair and work on that together. But I think a good way to think about it too is thinking about what does it feel like when I feel safety, and asking the people that you're working with too of what could they do to make this feel like a better connection. And in terms of trust as well, it's just following through with what you say and only offering what you can do, setting those expectations really clearly, and also having a very welcoming environment is important. Nice colors, plants, we all like those things that help you feel calm, cool, collected. Next slide, please. Okay, so employee strengths-based approach. This is also really important, but we only have 1 minute. So I just want to emphasize moving away from talking about people who use drugs and talking about behavioral care plans or behavior is really important to treating them like a good human being. And I know that sounds really obvious, but it's really important we shift our language and framing, again, to think about people's strengths. Just because a person's had trauma doesn't mean they don't have skills, abilities, goals, plans. Life is bigger than that. So it's really important to acknowledge the strengths that people come with in their work and do that in your documentation, do it in how you frame, how you talk about people who use drugs, that you're providing opportunities within your organizations for people to continue to build up their skills and build up their resilience, build up their abilities to manage stress tolerance. And that, again, we're not looking at people who use drugs as some sort of, as if they have deficits, that people are complex beings, and it's important to treat them as such when we're providing them with care and opportunities. And sometimes that means we have to shift how we think about our job. Our job is not there to fix people. It's to walk alongside and to look at how we can support and do things together, which can be harder sometimes. It feels really good to rescue or to feel like I can fix that in this broader context of work life being really hard, but generally people will push back on that or not show up to care when we do those things. So important to consider. And then just from an organizational stance, again, of allowing a lot of meaningful time for engagement and connection and planning, and to provide programs that actually have options that can be tailored to people's individual and maybe community-based needs, right? So it's, again, that common saying of nothing about us without us. Your best bets are to build things and get feedback from the communities that you're working with and talking about. And that translates right back into this trauma and violence informed approach, because it's all, again, about connection, safety, choice, and trustworthiness. And those are things that we can look at from a broader systems place, but it's also just in how you kind of be with the people that you're working with. And that, again, you come from a place of respect and not being the expert. It invites people in to be vulnerable and connect with you. And ultimately that's, what we both want in those situations. So I apologize. I had to rush through this ending. There's some key takeaways at the end for you to consider, but you can do that at another time. There are 2 pages of references for you also to dig in if you're nerdy like me. I really appreciate you taking the time to be here with us and to learn more about this topic. It is huge. So there's really a lot to learn and a lot out there for you to learn. And I did include some suggestions of reading and podcasts as well that you can dig into as well if you're more curious about it. Thank you.
Thank you, Christina. That was a really, really great presentation. Lots that you covered. I know probably could talk for another couple hours on this topic. I just want to thank all the participants for attending as well, and to quickly share that we have an upcoming BC Substance Use Conference hosted by the BC CSU. The link has been posted in the chat. You can check out the agenda on the website. It's on UBC CPD. And just a heads up that our next Lunch and Learn webinar will be on the topic of harm reduction. So more information and the dates will be shared with everyone who has attended today in the coming weeks, so keep your eye out for that. And with that, thank you so much to everyone who's attended today, and we'll see you next time.